Okay, it is with great pleasure that I am the moderator of this last symposium on cultural differences. We have just two speakers for this panel, and the first of our speakers is Jocelyn Wilder. Jocelyn Wilder is a senior research scientist at ORC and a valued colleague of mine. She has a research interest in systemic and structural racism, particularly the importance of place in systemic and structural racism. She has worked with, among many others, the United Auto Workers Retiree Medical Benefits Trust, Michigan Public School Employees Retirement System, and Blue Cross Blue Shield Medicare Advantage, which means she not only has great intellectual firepower that she brings to this question, but also a real strong sense of where and how the rubber hits the road for these questions. So with great pleasure, I pass the microphone over to Jocelyn Wilder.
I just have to orient myself to the clicker. And give it a test. Okay. And is it just the, okay, just, okay. Oh, perfect. I got the laser. Lasers in the middle. Okay. So, hello everyone. Again, I'm Jocelyn Wilder, and I am honored to be here today to talk about, contribute to the discussion on healthy aging. So I'm just going to say first, I'm always a nervous speaker in public. So I just like to get that out. It eases the room. But if you see me and it seems like I'm making eye contact with you, nod that you agree. You can nod if you don't agree, but you know, just so I feel like I'm connecting. So my talk is the ugly, the bad, and the good, and it's about racism and aging. And it's about social determinants of health and aging. And racism is pretty much a big social determinant of health. And it's something that is not in our control. And the bad is, let's see. Yeah, I always have problems with this.
Is there someone who?
Okay, it worked before.
Everyone's had this issue.
Yeah. Well, that kind of livens up. Am I like?
Yeah.
Okay. So we've got the ugly racism and its effect on aging, detrimental to it. We don't have any control over it. We have the bad, which are those barriers to healthy aging, and those barriers that arise out of racism. And we have the good, the acknowledgement that there is a problem and how surveys capture the experiences of underrepresented populations, and how NCHAP, the National Social Life, Health, and Aging Project, is actively rethinking on how to better capture the lived experience. So we'll try again. There we go. So first we're going to talk about racism. So all populations that are racialized as non-white experience racism. For the purpose of this discussion, we will talk about the experiences of those who are racialized as Black. And so this model is going to show us the distinct levels of racism. We have that internalized racism, that negative beliefs that you're less than, or the belief that you are superior. It is like, I kind of call like internalized racism is like, oh, Blacks, we're not good in math. We don't swim. And it's kind of like a gaslighting, like this manipulating of a population to make them question their own worth and ability. So, for example, if you think as Black population that if you were just more educated, you would have better health or better outcomes. That doesn't account for you running into interpersonal racism, which is that public expression of prejudice. So if I was just more educated, I would have better outcomes and a better engagement with my provider. But it doesn't account for my provider thinking that Blacks talking about pain are just pain seeking, or Black skin is thicker, so you don't feel pain. It also doesn't account for the institutional racism that doesn't have repercussions for carrying that thought. So there's like no rubber hits the road with a provider saying, hey, we're going to test you on your implicit bias, but you don't know that you have implicit bias, and you don't know that you are assessing one race differently than another. You just are. Which brings us to that systemic racism, which is that kind of collaboration across all of them. And it goes from, well, Blacks may be thinking, well, we can't show weakness. A provider may be thinking, well, they're just fine. They're not saying they're in pain. They really don't understand that the pain that they really don't understand the pain that they're in. They're saying it's an 8, but it's really probably a 5 because they got here, they're walking here, they've got their stuff done. So this is what we're going to talk about and how it affects social determinants of health and how it affects aging. So the first question is, do we grow old? Are Blacks represented in the aging population? So this is a slide of all-cause mortality and COVID mortality between February 1st and May 9th, 2020. And I want to show that if we looked at that age 55 to 64, that mortality rate for Blacks, 2,689 per 100,000, is a lot higher than what you see in whites of the same age, 1,693. So, and if you look down the line, that works, of all-cause mortality compared to, for Blacks compared to whites, you see that there's less and less of Blacks in older ages than there are whites. So we are less represented in that aging population. So this is looking at that same age group, 55 to 64, for all-cause mortality in that same period. And this is a disparity percentage. So you can see that for every 10, 6 Blacks have died, compared to whites, where you see 1 white has died for every 10. I just wanted to share. So, but what happens at age 85 is that all-cause mortality that tends to even out. Blacks and whites, once they hit 85, have pretty much same expectancy, the same rate of mortality. However, when we look at COVID, which brought to light a lot of disparities and inequities, it didn't bring to light anything that wasn't already known. COVID just exacerbated what was already happening in the population. And so you can see for that 85 group, 9 out of 10 mortality for Blacks versus 1 out of 10 for whites. So there's fewer Blacks aging in those older populations. The next is how we age. So it's our biological age. And thinking through our biological age is our organs might be older or younger than what we would expect from our chronological age. So say, are you 60 and you have the biological functions, or you have the disease prevalence of an 80-year-old, or you could have it of a 50-year-old. The caveat for the asterisk is that this is based on what is found in white populations. So it's that comparison of Black to white. But we talk about this weathering hypothesis, this early health deterioration because of cumulative impacts of social and economic stress, political marginalization. And to get a glimpse of what that weathering process contributes to is we're going to look at those activities of daily living, limitations by race. So these are snapshots in time. It's not following one population over time. It's just a snapshot. And you can see from that orange line that Blacks have higher prevalence of ADL limitations, walking, dressing, bathing, eating, transferring, toileting. And they also have a higher prevalence of ideals, preparing meals, grocery shopping, using the phone, compared to their white counterparts. And again, this is that age before you become considered a senior citizen or an older adult, that 55 to 64. So we get to the bad. And we have lower representation in older age populations. And it appears that one reason could be due to that accelerated aging, which is caused by that social and economic adversity, and which is affecting our population's ability to age healthily. And I just want to share this quote by Audre Lorde, that there is no such thing as a single issue struggle because we do not live, well, we do not, sorry for the missing T, live single issue lives. And this is because healthy aging is not a solo endeavor, it's a community endeavor. And we have that racism is a social determinant of health, and it's one of the major social determinants of health. And on the left side, we have a lot of the isms. And you don't just actually probably have just one ism that you're dealing with, you're probably dealing with multiple isms. We don't have just one thing. It's just not living that one singular issue. And then on the right, you have those kind of identified social determinants of health. And that's the same. You don't just have poor education. If you have poor access to a grocery store and food access, you probably have poor access to transportation. If you have poor access to a grocery store, you probably also have poor access to a pharmacy, which is going to impact your ability to get your medications and be adherent to your medications. And we know, we all say that, hey, a healthy diet is a key component of a healthy life. However, predominantly Black communities have poor access to grocery stores, they have poor access to pharmacies, and these communities also experience more exposures to environmental pollutants. And these things don't just impact you when you turn 55, 56, 57. Healthy aging is something that starts at infancy, something we should be concerned with from the beginning. It's a lifelong. And so if you are experiencing any of these or multitude of these from infancy, it's going to impact how you age at 60, 65, 70. So we have a challenge. So data shows that Black communities experience poor access to resources, they experience accelerated aging, and that they're dying earlier. And we know this because the data tells us. And data usually tells us this in comparison to white populations. And that comparison shows us where things are unequal. But we need to examine the strengths in Black communities because the data really shows us the lived experience of Black populations. It really shows us the huge variation within Black populations, or it doesn't show us an asset approach when examining Black populations. So for example, when we're looking at those super seniors, people who make it to the age 85 and older, what could we learn from that population that we can share with younger populations who we see are dying prematurely so that we can decrease that mortality by age? So we've journeyed through the bad, the ugly, we journeyed through the bad, and so now we're going to get to the good. And this is ways in which NCHAP is actively rethinking how to better capture the lived experience of those racialized as Black. And that is one, to have the diversity of experience, capturing the full effects of racism with those who examine the phenomenon, and inclusion, partnering with communities to develop measures and disseminate findings, contributing to the examination, well, creating a sense of belonging that moves towards a justice. So a shared fate, which will affect you and me, and we're in this together. And it contributes to the examination of the systemic issues and puts a burden of change on the system and not the individual. And so how do we address it? Diversity. We work on increasing the representation of underrepresented groups in our sample. In this way, we can examine within group differences. Instead of comparing Blacks to whites, we can compare Blacks to Blacks, Native Americans to Native Americans, Hispanics to Hispanics, and look at those within group differences and see what are strengths within those populations that we can share within those populations. We can address intersectionality. Again, we don't just have one identity. We are dealing with multiple isms and multiple social determinants of health. So these would address the assumption that the lived experience among Blacks is the same. We usually capture Black and African American together, and it could be completely different. We could be capturing someone who's from the Caribbean versus someone who is descended of slaves versus someone who's from the continent of Africa. And they all have different lived experiences. It addresses the assumption that people only have one identity, that you are Black, but you're also Black. You also could be a Black woman. You could be a Black man. You could be a Black woman in a wheelchair. Again, we always have multiple identities. And it's a guideline for researchers to explicitly state who the data and the findings represent. So we always talk about studies and generalizable. Who can we generalize these studies to? We have to explicitly state who we can generalize these studies to. Equity. Incorporating questions that capture cultural experiences and the full spectrum of racism. So from that list, we had internalized, interpersonal, institutional, and systemic. And at this time, self-reported race is a proxy for all of those, including cultural differences. So we're thinking through what questions can we get to see what the spectrum of racism that people are experiencing is. So some studies have found that higher income Blacks have more instances of personally mediated racism. Lower income Blacks deal more with structural racism, lack of resources. But they may not even realize that it's a lack of resources. They just think that's the status quo, that their community they don't have it. It's not that they're supposed to have it. So even in Blacks, different types of racism may be impacting us differently. Inclusion. Oh, that's not sorry. Time for me to do my timesheet. Okay. I forgot to turn it off. Inclusion. And this is about establishing a community advisory board, getting people from various communities. So we're dealing with a national survey, but thinking through, there's regional differences, there's cultural differences. We have to think through, help people who can help us understand if we're asking the right questions. Addressing the assumption that all questions mean the same across groups. I know they always use the one in the CS, the one about, do you feel blue? And I know they've taken that one off because I think they have, because people interpret that differently. But also thinking through that presentation of illness is the same across groups. Some cultures, mental illness is such a stigma that they really only present with physical symptoms. And the questions on the CSD are not going to capture those physical symptoms of pain or aches. Thinking through guidelines for researchers. You identify community organizations with whom to share your findings, getting that knowledge out there. Also, the inclusion of historical context. So this is kind of an old one, but it's a goodie. It's the Framingham study that is used for a lot of cardiovascular risk assessments. But the Framingham study was predominantly white New England men. So that's not even generalizable to someone in Kansas. So we have to think through if we're citing something, who was that study actually capturing? And so the goals of these changes, it's kind of that move towards justice, kind of moving away from thinking around the differences of Blacks as being an individual attribute and what does this Black person need to do to have better health, but moving towards how can we impact the system so that everyone has better health outcomes. And this is making right wrongs due to the lack of representation, equity, and inclusion. And I'm done, so.
Okay, we have time for, let's say, 2 questions. We'll move on. Thank you so much. Oh.
First of all, I'd like to say I agree with this astonishing high proportion of what you said. I couldn't possibly do everything anybody says on principle. But I do think you raise a very important issue, and we are addressing, plan to address which is that although we did oversample in round 1 and in round 3 for African American and Latinx population, we did not take into account the very rapid attrition in the population. Very few people left in the older age group, in the 2 populations. And our plan is to supplement both cohort 1 and cohort 2, those are people who are now between the ages of 55 and 100, with additional members of the African American and Latin. We simply don't have data anymore. We very few enough data earlier. I would also like to emphasize or re-emphasize what you said about the meaning of questions to different people. And I don't think that's purely a race or ethnicity question. You mentioned New England and Kansas. Yeah. I've been to only one of these 2 regions. But I'm willing to believe that the wording in our questions does not mean the same thing. Yes. To people in these 2 regions, and we have not been sensitive to this. And as a survey researcher, we focus on standardizing the question, but perhaps we should focus on standardizing the meaning, which is not.
No, that's a good point. Thank you.
If these were only words of praise and beautiful ones, then I think there was a question over here as well.
Actually, I think it's a good kind of segue from your point, which is that you bring up this interesting tension with inclusion and representation, right? You want to make sure questions and their meaning are kind of meaningful to different groups, and you want to make sure that things are generalizable across populations. But there's a tension there between doing that and making it this culture, but then also not, when you're analyzing and making arguments, saying, well, that these outcomes are due to race or they're due to culture or that kind of thing. So it's an interesting balance.
Yeah, so it's not gonna, I don't think it's gonna get solved in one day, but it's moving away, definitely. But like one questionnaire, it's gonna be multiple questionnaires and iterations. But I think it's that the inclusion hasn't happened and the representation hasn't happened. And so we're starting to move to higher representations because it's a sample size. I can compare the Black population to the white population, but I can't get nitty gritty and figure out what's happening in that Black population or what's happening in the Hispanic population or that Native American population, because I don't have the representation. And then part of that inclusion is, yeah, it's not going to be perfect, but we're moving to just better than where we are right now.
I saw your hand, William, but we really should move on. So I just hope that you can connect on the question afterwards. Join us once again in thanking Jocelyn Wilder. And our next speaker, Dr. Lisette Piedra, Associate Professor of Social Work with appointments in Latina Studies and Women and Gender and Global Perspectives at the University of Illinois Urbana-Champaign. Dr. Piedra's work bridges traditional academic and community-based studies with an interest in caregivers, social networks, and she has been supported by Mather Lifeways, National Institute on Aging, and her work has appeared in a list that it would take far too long to recite here in how many journals she has been published in. So join us in welcoming Lisette Piedra.
Thank you. Okay, is it okay if I just not use a microphone? Would that be okay? Everybody can hear me, right? Okay.
The remote people would have a hard time hearing.
Thank you. Okay, for you guys at home, we will use the mic. But first, I want to thank you for making this possible and for, inviting me to be here. I really am taking this as an opportunity to talk about a topic that's very near and dear to my heart. Language issues, ethnicity. Whenever we think about ethnicity, it's very easy to fall into the trap of just talking about cultural folks or communities, or we're talking about Hispanics or some other kind of cultural trope. But when it comes to the actual access of institutions that facilitate aging, whether or not you speak the dominant language, it seems to make a really big difference. And so many years ago, not many years, actually it was about 3 or 4 years ago, I came across Jacqueline Angel's and her husband Ronald Angel's work, and some of their wonderful statistics that show that among Latinos, they do live longer. But those last 10, 15 years are in really poor health, which really I found very odd. I'm like, what's the point of living longer if you're in really poor health? And then on top of that, who's taking care of these people? And there's the sort of cultural myth that, well, their families are going to take care of them because they're very family-centric. But the reality is that over time, Latino families begin to look like most American families. The kids grow up, they move away, and so increasingly, these families are taking care of their relatives, but not necessarily engaging in the day-to-day caregiving. They're relying more and more on their neighbors, on church people, on their friends. And so that really started to raise the question of, we know that if you're going to help dementia, or you're going to deal with dementia, the most important things seem to be lifestyle. In the absence of a drug, in the absence of a medication, we are really left with lifestyle change. And we know which are the lifestyle changes that seem to make a difference. But somehow, these communities are not getting access to this information, which made me begin to wonder, well, maybe it needs to be culturally adapted and put into these communities. And so we started to do this, and it was part of this wonderful project that I know Melissa does not like me to mention her name, but I'm going to do it because this was her baby. That's how I became involved with NSHAP. And so, but we did a positive aging for Latino studies, in which we talked to workers and we talked to scholars, and we did an analysis with Latino older adults. And what we found is that if you look at what positive aging means to these 3 different stakeholder groups, they actually have very different ideas about it. And there were some similarities and overlap, but there was differences. And these differences are important because the scholars are generating the research, the workers are providing the services, and the clients are saying that we want something different. And some of the things that really seemed to matter to them were things like having relationships, not necessarily always with their families. They actually, when they looked at the priorities, it was less important than their good relationships with their neighbors and friends. They were pretty important, but they were just under. And so, and they were also really interested in this idea of taking disease, which we have sort of taken it to mean basically dealing with stresses, which is also another important thing about aging, being able to manage stresses. So we had this sort of dynamic. So then we developed, Melissa and I put in a grant, and we got this grant for the Illinois Positive Aging for Latino Studies, in which we basically took extension curriculum and tried to adapt it to Latino older adults. And what we found is that in the process of doing this adaptation, language issues seemed to came to the forefront. They were like, well, how do you say this? And does it resonate with Puerto Ricans? Does it resonate with Mexicans? Does it resonate just in general with people? I'll give you an example. I just came back from Spain 2 weeks ago. And when I was there, I had this meeting. My colleagues and I, James and Melissa, we just turned in this big grant. We just pressed it today. And this grant is about studying language issues. The thing is about studying language issues is that, I'm here in Spain. I know we're going to be submitting this grant, so it's all in my plan. So at every opportunity, I'm talking in Spanish to as many people as we possibly can. But I know that the minute I open my mouth, A, they can tell I'm not a Spanish speaker. They can hear my Latin American accent. And B, my Latin American accent is really, English American accent, but it's actually, it's painful to me, but there, I can make myself understood. So so my husband and I had to change things around, and we're at the conductor, and he's explaining to me that he goes, you have to, when you get to Avima, you have to change plazas. And I'm geographically talented, and so I thought we have to leave and go to a different station. And he's like, no, stay on the train, we're going to change plazas. And I'm like, I understand every word he's saying in Spanish, but I have no idea what he meant. And it was a very weird sensation to understand the language and have no idea what that means. In English, right? How many of you guys took a lift to this floor today? Yes, elevator. So, lift versus an elevator, right? It's so within the same language, you have variations, and it depending on what what's your educational background. So for this poor conductor, I'm having it explained to me at the 8th time, what exactly do you mean? And it occurred to me that plaza is a Spanish word for seat. You have to change seats. You stay on the train, you just have to change your seats. And I was like, so now I'm a college professor. I have a high level of education in English. And so my subjective sense is my social status. I mean, this conductor thinks I'm an idiot because I didn't understand the seat thing, but I know I'm not, and I can laugh it off. But imagine if I have a lower level of education and I'm navigating a language that isn't my own, and I have a low level of education in my original language, right? So your reference point is different, and you're navigating a language that's difficult. And you can be sympathetic, right? Because you can imagine how difficult that must be. But if you imagine how much exponentially it affects people in this country. So in preparation for the study, I started looking at the statistics about, just basically demographics, how much have they changed? And so, and Melissa did not want me to read, but I have to read you my statistics because I can't ever get the numbers correct. So, compared to 1980, there has been there is a 194% growth in the people in this country who speak another language. And of course, the biggest group is Latinos and Spanish, but it's not just them. There are now 90 million more people in this country who speak Chinese compared to 1980. The United States is now one of the most linguistically diverse countries on the planet. Maybe we're like number 6. It's crazy. But we operate as an English-speaking country, and so that impacts the kinds of services we have. And we are much better at it today because of laws that say you need an interpreter in the medical context. But the reality is that healthcare doesn't happen in that healthcare provider context. You have pharmacies, you have rehab, if you need any kind of specialty services. So, and what happens afterwards if you have a question, to make an appointment. So in all of these facets, language barriers become problematic. And as you age, they continue to become problematic. And the fact that we know so little about how language affects the aging process and how it affects the caregiving process is all problematic, which is why we're so enthusiastic about this grant. So as we're looking through this literature, it turns out that there are real things that happen in the bilingual mind or in the multilingual mind as we age. And one of the things that happens is that first of all, once you know a second language, you can't unknow it. So you always are operating from a 2-language system. And one of the reasons that makes it possible for people to switch languages is that you're inhibiting irrelevant information as you're focused on one particular language. But as we get older, our ability to inhibit information becomes less and less. This is why you're like, okay, I'm supposed to do this, and you remember all the other things you have to do, and then you say, what was I doing again? And part of that is that it's sort of a natural thing that happens over time. The other thing that happens is that language is very cued. So if you are in a context in which everyone around you is speaking English, even if you're having accented English, you're going to use it because everyone around you is using it, everyone's expecting it. But imagine if you retire, or imagine your kids go away, you know, they go away to college and no longer at home, so they're not speaking English. And so now it's you and your friends and your spouse and your neighbor and everybody around you is speaking your primary language. So you get this sort of language reversal. So you have the natural aging process and the fact that you're probably in contexts that are cueing you. And then you have, on top of that, if you have any kind of cognitive decline, you have an acceleration of these processes. So if you think about the caregivers, what that must be like. So someone who might have been bilingual 10 years ago, all of a sudden is really needing services in the primary language. And you're having to deal with that person in that primary language, but while you're dealing with dominant, you know, English speakers in the service systems, and you might be dealing with neighbors in another language as well. So you get a complexity that we haven't quite gotten our heads around and thought through, how does this affect the caregiving process? I'm just gonna check the time here. Because once I get going, I lose track of time.
Oh, Lissette, there's a clock on the wall back there too.
Oh, I can't see.
Oh, yeah, that's right.
Sorry. It's a little bit of that. Oh, I'm out of time. Am I out of time?
You can go a little. Yeah, exactly.
So, so studies coming out of Europe see that they're very used to multilingual populations. One of the things that they observed is that if a person is older and they're retired and they're living in an ethnic enclave, they're going to be less lonely. They're going to have a lot of sort of good stuff that's available to them. But the likelihood of having someone in your social network that speaks the dominant language is diminished, which means that you're fine until you're not fine. You're fine until you need an emergency room visit. And then all of a sudden, having someone in your network who speaks the dominant language seems to make a difference. And so you get this kind of paradoxical effect with language. On the one hand, bilingualism is actually very helpful to the brain. If you learn a second language in older adulthood, that seems to really help. In Europe, they're really pushing bilingualism as a way of dealing with cognitive decline. On the other hand, you have all of these complexities that are related to dealing with institutions that may contribute to people's stresses as they try to access them, or not understanding things, or not being taken seriously, or being misdiagnosed or underdiagnosed, which is a very common problem in this population. And we heard from Dr. Doyle, the earlier you get diagnosed, the better you are. The fact that there are low levels of education in this population also contributes to the fact that they're more vulnerable to having dementia. And so all of these factors come together. And so on the one hand, one of the things that does need to help is giving information, providing interventions on lifestyles. But the tricky part is packaging those things in a way that is culturally sensitive or culturally resonant and in a language that's accessible, and then getting it through the dissemination pathways. So it's not so much just a vaccine or medicine, but that you now are able to mass distribute it and getting it to the right people in the right time. And all of those are problems that researchers are grappling with. But the other piece of it is sort of getting a handle of what are the characteristics in these networks and how language is affecting families and communities as people age over time. Doing this in the context of a country that historically operates as an English dominant language in the presence of all of this linguistic diversity. So I thank you for hanging in here with me, and I'm going to give this back to you.
Okay. We will also leave you 2 questions here.
So, I'm sorry, information, anybody's announced that we are not having the last talk in this.
Yeah.
Because the speaker has closed.
So unfortunately, Michelle Johns cannot be with us here today. So that was it. But I'm sorry.
So she's not here.
I'm afraid not. And I don't think online either. But yeah. So 2 questions maybe we have time for Lisette. Yes, William.
Lovely presentation, thank you very much. I foresee an organization that's really focused on older adults with cancer. So we talk about ageism a lot, and that's been our sort of ongoing mantra. But now we're encountering this intersectionality challenge of being older and being in other categories that are racism and other forms of discrimination. Do you have an idea how to think best about that? Today, I heard mostly about racism in older adults, but there's ageism on top of that. And I'm wondering if you have any thoughts about how to think about that and how to address the two issues.
Lisette, would you be able to come back to take the microphones? And for people who are watching, the question was about how to address intersectionality in this topic, and especially around intersections with ageism.
Okay, that is a really good question. And I hope I'm going to do justice to this question. One of the brilliant things that Melissa did with the positive Latino studies, and then we carried it to the Illinois positive aging study, is that we have a community board of older adults who provide us information. And one of the things that we have heard from them is oftentimes information is provided to them as though they don't understand it. Like so they called it, I think they called it elder speak, where you're talking, it's sort of younger people thinking that older people don't quite understand, so they're talking slower or they're talking more simplified, and so it feels offensive even though they mean well. And so you get that kind of piece going on. And then you get the piece of just not recognizing that even if you have a translator, or even if you have the material available in the language, the target language, does the person really understand what it is that's going on, you know? And the other piece is that giving people the time to sort of express themselves. And that is, I mean, I've been in Europe multiple times where I literally take calls from they'll call me, they're like, can't make the meeting, and I'll pick up the phone in Spain. I'm like, I will see you in 2 weeks, you know, because it's important for older adults to feel honored and respected. And, you know, so I hope I'm getting at your question, but some of these dynamics are, we're not a culture that's used to dealing with older adults. You know, other cultures handle that scenario better. We're sort of, this is a test run for us, right?
Yeah, and I've been wrestling with that. It's one thing to be older and have the differences when you're older that you have to deal with. That's separate from ageism because you're older.
Yeah.
They're different issues, and they interact with each other, and now we have these other issues to deal with. Again, just looking for advice, so thank you.
I'll give you one piece of advice. One of the things that came up in our paper about do service providers and older adults agree? It turns out that you got to remember, service providers are younger. And so we have the biases, or they have the biases of younger people. And younger people are very concerned about safety, whereas older people were very concerned about quality of life. You know, and so they're willing to take a risk, you know, that younger people are not. They're like, no, you may fall. And the person's like, you know, my uncle's 88, and during COVID, I turned to my cousin, we were like in front of Trader Joe's, and there's a big line, and it's a big sign, we will deliver. And I turned to her, I said, she's like, they live to go to the store. You know, they're in their 80s. My aunt was like mowing lawns, you know. It's like, so to a younger person, you're horrified, right? But to an older person, they're like, well, these behaviors are what helped me live this long. And so there's a tension between quality of life, autonomy, the things that is all about being an adult, and safety and protection, and you get that tension. So you can't assume that they have the same agendas.
Maybe do one more short question. Maggie?
So you've got a question back there.
Maybe more of a comment. I'm really interested in this first study that you guys did together about the cultural differences in the definition of healthy aging, and the personal goals that people select for themselves and how that differs across cultures. I think there's been a movement, at least in geriatrics, to try to incorporate personal preferences and healthcare goals into decision making, but it didn't even cross my mind that maybe different cultures have different goals. And so I'm just, I know you're not in the clinical space, but thinking about how we can best incorporate that into our clinical treatment targets and how we ask patients about that or sensitivity. Maybe be more considerate of how we can recognize that there might be these differences, maybe tailor care to meet their goals a little bit better.
Yeah. Atul Gawande wrote this beautiful book called Being Mortal. And it was about his father dying, basically, and how they dealt with this tension between what the family wants and what meant dignified care for him. And so having those conversations are really important. But I think there are also conversations that need to happen with the family as well, because there's oftentimes tensions, and helping families have mixed opinions, and that space to wrestle out those mixed opinions, I think is going to be important.